And then hi, everyone, and welcome to our presentation on how to leverage the rulemaking process to impact policy. This is going to be a discussion that teaches you, the everyday person, how to advocate for policy change. My name is Ashley Kamembin, and I'm a member of Doctors for America. I'm also a second-year medical student at the University of Illinois. Before we get started, I want to take a quick minute to invite you to officially join Doctors for America. Being a DFA member today means taking the important and simple step of selecting a membership level and paying your annual membership dues to support DFA's organizational sustainability. We'll be live streaming to Facebook Live and making a recording of all the materials which will be available afterwards. A few quick ground rules for the educational session. There's no such thing as a stupid question, so please feel free to ask all your questions, but please use the Q&A feature. We'll be monitoring throughout the chat and making sure that ARCA gets all your questions and is able to answer them throughout the presentation as well as at the end for the official Q&A session. Now on to today's speaker. We're thrilled to welcome ARCA Deb as our speaker today. ARCA is a psychiatrist and preventive medicine physician. He has previously been a physician working for New York City's public hospitals. He has now transitioned to full-time work with the federal government while maintaining clinical practice and residency teaching responsibilities. His work for federal government is at CMS. At CMS, he works on teams developing payment policies with annual regulatory updates for the Medicare physician fee schedule, outpatient prospective payment system, clinical lab fee schedule, and other payment systems. As an HHS medical officer and psychiatrist, he is also called on to consult on a variety of national behavioral health policy issues. While previously leading the Gun Violence Prevention Action Area at DFA, he helped to organize the DFA 2021 campaign to voice members' opinions on ghost gun-related safety measures to the ATF. This required thousands of DFA members to participate in the ATF rulemaking process. Now, I'm thrilled to pass it on to ARCA for our presentation today.
Thank you, Ashley, and thanks everyone for being here. And let me put my slides up here, which I believe, if I can just get any thumbs up or any indication for anyone that they can see my slides. Appreciate it. Are my slides visible? Yeah, I'm going to take that as a yes. Let me see. Okay. Thank you. So, I guess a couple aspects of this. So we want this to be interactive in a couple ways. So I will ask questions during the talk, and if you and although we're not having sort of attendees speak, if you can put answers in the chat, I'd appreciate that. So please put answers in the chat. And also we're going to stop in a couple times during the talk to see if there are questions. So yeah, if you have questions, please put them in the Q&A, okay? And Ashley will be checking them out, and we'll stop a couple times to go over those questions. But when I ask questions, if you could put those in the chat. All right, so we want this to be interactive. Please put questions in the Q&A. Okay, so this is about Rulemaking 101. What is Rulemaking 1? What is rulemaking? So it's something I do, or I guess I work on for my day job. I have to go over a couple disclaimers here that the opinions I express at this meeting do not represent CMS viewpoints, right? This is me sort of me being a private citizen right now, and sort of helping people know about their sort of opportunities to give public input. Much of my day-to-day work is considered confidential deliberative procedures, so I cannot share specifics. If you ask, what was the conversation like when Ashley came to CMS and negotiated for something, I can't say what's going on there like that, but I'll just put in an extra little disclaimer that the truth is you can still FOIA, meaning Freedom of Information Act requests most federal employees work. Anyway, so just a couple of disclaimers there. So what's the plan today? To talk about notice and comment rulemaking. That's the technical term for it, okay? And the process of rulemaking and the rules of making rules, right? What are the obligations we have as federal agencies when we're making these rules, and what are the health impacts? Then we'll go over a current proposed rule that may impact access, right? That actually originates from CMS, but not from my offices. And again, this is out in the public domain for people to comment on right now. Okay, so what is notice and comment rulemaking? So rulemaking, why does it matter? Okay, so the graphic I have here is that, well, why can any federal agency engage in its sort of public good and its public task, right? The FDA can engage in its responsibilities because of the FDA Act, right? Because of the Food and Drug Act that allows it to sort of monitor safety and efficacy and sort of also recall things from the market that are food or drug components, right? Medications or device components. So there's laws in place that Congress puts into place, and the White House either signs into law or a veto-proof majority overcomes that. But so Congress makes laws, our representatives make laws, after Congress makes laws, Congress cannot make laws to actually keep up with the sort of the everyday nuances that go along with completing the tasks that are laid out. The FDA, the ATF, the Alcohol, Tobacco, and Firearms Agency, CMS, where I work, Congress could not have possibly legislated in its laws, even those laws are thousands of pages long. They can't possibly legislate what you do for an ever-changing environment, such as in the Medicare fee schedule or CMS or just healthcare in general. There are hundreds, thousands of new sort of procedures or services that occur every year. And in fact, there's lots of new findings for, well, how do you diagnose someone with something, or how do you treat someone with something, or how do you identify people at highest risk for harm from a illness or from a treatment. There are new findings all the time, every day, and that's why we have to do continuing medical education. So there's no way Congress could have legislated everything that an agency like my agency, CMS, has to do every year, has to look at every year, especially like my agency has to complete the fee schedules every year. So an agency like mine, like CMS, has to put out regulatory updates, and I have in capital rules every year. So those are regulatory updates of how they will execute. Again, we're part of the executive branch, how we'll execute the laws that the legislative branch put into place, right? So, even though a law is passed, we need regulatory updates to make sure that those laws can actually be executed, okay? Beneath that is there's guidance and technical decisions as well, which means that agencies, again, CMS, the FDA, the CDC, and outside of HHS, the Transportation and Security Administration, USIS, within the State Department, USAID, they all have to put out guidance and technical decisions, whether they're putting out grants or contracts, whether they're describing how they're going to enforce the law. Within the IRS has to put out sort of guidance and technical decisions on how we can all sort of submit our taxes. So there's regulatory updates every year, and then there's guidance and technical decisions. So what's today about? So today is about those rules, the regulatory updates in the middle. Now, who's writing the rule? Okay, let me actually take one step back. Again, who's writing the law? Those are our sort of representatives, right? Those are the Congress creates these laws, and often the public is involved in sort of drafting the law or sort of suggesting to Congress how to write it. The regulatory updates every year. Congress can't do that again, right? So who's writing it? Well, it's written by human beings. Like myself, I don't actually usually draft that much. I'm one of the physicians. So this is a reason to delve into what I do, I suppose. So within CMS, there's about 50, 60 doctors, right, in the central offices that help the bureaucracy interpret everything they need to interpret to complete the sort of healthcare payment for the Medicare and Medicaid programs. So the physicians like me have to sort of deal with incoming input about, well, this diagnostic test, it seems to be able to do this, it requires this many resources, and it helps our Medicare beneficiaries this way, or Medicaid beneficiaries this way. And we also have to say, well, are some services similar to others? Like, and I won't go into, I can't give a specific decision on things here, but, so people have every right, things that are out there right now, people have every right to ask, well, is a colonoscopy the same as using the Cologuard, the Cologuard test that you can do at home, that kind of thing? There are differences, right? But relatively speaking, where does it fit in? So who's writing the rules? So it's human beings, I put here. I'm being a little bit facetious, but I think it's a good reminder. It's not a computer doing this. There's about, for my agency, again, there's several thousand employees, basically 6,000 employees. And even though there's 6,000 of us, the amount of work that we have to do, or the amount of things that all the bureaucrats have to go through, we still have a finite amount of time and energy and information to work with, and finite experiences. We're government officials, so we took an oath of public office, right? And we're professionals of various credentials and backgrounds. And that's just a picture of somebody, of a professional in this position of trying to figure out how to do the right thing. This what a government office could look like, or now that a lot of us are remote, that could be what someone's home looks like as they're working for the government. Examples of federal agencies with proposed rulemaking. So CMS fee schedules, like I said, so the Medicare program every year has to put out an annual update because of what I said earlier, because healthcare is evolving rapidly, right? In fact, Congress has required that as new services are defined in certain ways, the Medicare program has to at least look at what that new service is and assign it some value on the fee schedule. It could be zero. When something's new, we could say, well, this actually may not have any value. This may be completely experimental. And we could say that, that there is no national fee schedule price on it, but we have to at least deliberate and make that decision. Or we can put a price on it and say, yeah, this is similar to, stereotactic craniotomies to ablate seizure focus. Or we could say this is more similar to adaptive behavior, applied behavior analysis for autistic spectrum disorders treatment, that kind of thing. So the CDC puts out clinical practice guidelines for opiate prescribing, puts out clinical practice guidelines for lots of things. But this past couple of years, they had to put out guidelines for opiate prescribing. FDA creates licensure requirements for wholesale drug distributors. There's a smaller list of all those drug distributors, but the FDA could create licensure requirements. The TSA has protocols for what has to happen when we enter into airports or otherwise, right? FINRA, that's like financial regulatory. So point being that this is going on across the government. Now, all these agencies have these proposed rulemaking processes, right? There's some rulemaking processes that we're not too privy to, such as things that deal with national security, where it would be against the national security to put something in the public domain, right? But in any case, these are examples of things that go through proposed rulemaking. Again, where I work, Medicare regulatory updates cover the physician fee schedule and a couple other things. I won't go into some details here because I want to get on to questions, and I want to see if there's questions from other folks. But anyways, that prospective payment systems for hospital-based things or ambulatory surgery-based procedures, inpatient prospective payment systems, the clinical lab fee schedules, all-inclusive rates for federally qualified health centers. As an aside, where I work on Fridays is a federally qualified health center. So clinical fee schedules impact. So what's going through this rulemaking process? Well, these clinical fee schedules can impact new or existing services. Examples are, what are telehealth covered services, collaborative care for primary care and behavioral health, hospital DRG payments, hospital GME payments. Who decides what can be covered? I'm gonna check this chat here. Do you know how the nation decides? How does CMS decide? What programs, what GME positions can be covered? What decides if a hospital can declare it has GME positions, residency programs that can be covered? Does anyone have an idea of that? We can go back to that question later if no one has an answer. I know we have a smaller group of participants, so okay, we won't go back. Well, actually, I'll just say, so for GME payments, for a program, for us to recognize that a program is a legitimate graduate medical education program that trains residents to become licensed and then board certified doctors, we require that the ACGME, a private entity, a non-governmental entity, accredits that residency program. So that's actually written into law that the ACGME decides which programs are accredited or not. And then we decide which ones can get GME payments. And well, we also decide if they're acting faithfully with CMS to give all the information that's required or not. New or existing device payments for medical devices, right? The medical devices are everywhere, whether they're implantable or monitoring us, or used to complete procedures. Bundled payments for ambulatory surgery. Okay, so what happens in this notice and comment rulemaking process? Okay, well, so let's just say this screen represents a year. Okay, again, my agency has to put out annual updates, annual rules. So I put sort of the public comment period in the middle and put a little slash because that's where we need to sort of work. Let me also check the chat here. Okay, anyways. Thought I saw a chat, but that's okay. So what happens here? So
sorry to interrupt, Arca. The chat was down for a little bit, so I'm sure now that it's open for all participants, they'll be typing up their questions in no time.
Oh, sure. Thanks, Ashley. Appreciate it very much. Okay, so what happens? So this is sort of representing a timeline. Some people have went to business school, which I did not, may recognize this as sort of the Chevron closed system for how something was passed. Again, Chevron does not have an interest in my work at CMS or anything. It just happens to be sort of that type of graphic. Anyways, so if this graphic represents a year, I sort of put a dent in the middle here on how it sort of timeline works. And at the beginning, we have stakeholder input into before what happens here. Agency releases an NPRM. What's an NPRM? If you look at the bottom of the slide, NPRM is the notice of proposed rulemaking. That's a proposed rule. Okay, a proposed rule. So stakeholder input can be, and what is stakeholder input? Okay, stakeholder input can be anything. Okay, stakeholder input can be sort of someone talking to their congressperson and the congressperson knocking on our door. Could be people emailing us during the year, right? It could be people having meetings with us and telling us such and such. I'm saying people, it could also be organizations, right? People, they're kind of different. They're different, right? So I mean, they're and the people that we're most sort of responsible for is beneficiaries, right? Medicare beneficiaries. They're the ones we have to worry about, meaning we have to ensure their health care continues. Anyway, so stakeholder input is always going on, although I put it at the beginning, it's always going on. But before stakeholder input, an agency releases a NPRM. That's a proposed rule. So with stakeholder input, we can draft a proposed rule. Now I'll just sort of make an example for our physician fee schedule. The proposed rule usually goes out in the summer, right? In the summer, like a proposed rule went out in July for our physician fee schedule. And why is it proposed? It's proposed because it's not final. It has to go through notice and comment rulemaking, right? It has to have this period afterwards, a public comment period. And comment periods can last 30 to 60 days, usually. Sometimes they can last longer or shorter. I mean, they shouldn't last less than 30 days. I don't see any that last less than 30 days. But comment periods can last 30 to 60 days, right? And I guess I'll just focus on that now, because we'll go into an example later of something that's in a public comment period. Then after a public comment period, an agency writes its final rule, meaning sort of after, say, a comment period for the physician fee schedule ended, 3 or 4 weeks ago? Right, so it ended maybe 2 to 3 weeks ago, and then we have to write the final rule after we get all the public comments. Then we have to sort of sit and say, okay, all the stakeholders said this. We have all this guidance. We have all this expert opinion within the government, outside the government, with our watchdogs and everything. Then eventually, a final rule has to be released. So I guess we're in this. I'll say for the physician fee schedule, we're in this period of rule writing right now, where it's actually kind of a sensitive period where we can just listen to folks, and we're not, and it's a time that's actually in a way sort of protected for us, where it's important that we're not bullied by any one organization, right? Because theoretically, it's just the strongest organization with the strongest resources could bully us into just saying, well, forget about people with less resources, which, can create all the disparities. So theoretically, we're kind of protected during this time when we're rule writing. And then we release the final rule, like this for the physician fee schedule. That will be, that's usually planned around November, I can't tell you exactly when, because these are rules that, I'll be honest, that this is things that my colleagues are working on and I have to sort of contribute to. I can't say exactly when, but it's usually released around November, to be enacted January 1st, 2023. So this is an example. So I'm giving the physician fee schedule as one example that goes through this year-long process. So, and I just sort of, so, okay. So then, so that,
We have a question.
sure. Let me see.
Okay. So should I read it out to you? Would that make it a little bit easier?
I think I see it. And I think this is more of a general question. It's not necessarily about this. And I'm a preventive medicine resident. I'm curious about how you first got started working at CMS. I'm interested in learning more about opportunities in the federal government. I'm going to save that for the end so that we can get through the content of this. But I'll say that immediately you apply through usajobs.gov, and those jobs are all available. But then we can speak a little bit more about this at the end too, because I want to go through this process a little bit. You know, it's not what I guess I'll say more important than my being at CMS is, the truth is, if I wasn't at CMS, but we had a lot more people participating in rulemaking, then you know, that's the more important thing that's in our process. Like, everyone in the government will say, well, we need feedback, especially the feedback that's going to help our beneficiaries, right? Our main stakeholders, you know. Anyway, so I'll keep going, but I'll just give a tidbit. At usajobs.gov is where you apply for medical officer positions, whether it's for the FDA or CMS or otherwise. But let's keep going here. Okay, where am I here? Okay, so proposed rules look like blah. Okay, here's an example that we're going to talk about right now. It's out for public comment right now. I'm not involved with writing any of this, so that's kind of convenient because I shouldn't be talking about anything that's sort of private. And the good news, I don't know anything private about this rule. There's a rule out there called, and it's written in this, it's written like the way the old encyclopedias were written. I don't know if anyone here used to sort of look at encyclopedias like Encyclopedia Britannica and stuff. It's written sort of in the long form. It's 96 pages long, written like this. It says streamlining the Medicaid Children's Health Insurance Program and basic health program application, eligibility determination, enrollment, and renewal process. Okay, so this is a rule that's out there right now. Where is it? It's at this place called in the Federal Register, fedrog.gov. We'll find the website in a second. And why is this out there? Okay, so what is this supposed to be doing? And why is it written this way? Okay, well, they look like this. Okay, so we're going to get to that more specifics, but I want to step back a second here, and I'm going to ask some questions too. Well, who has authority over rulemaking? Really, this rule belongs to the constituents, it belongs to the people. And but we have the authority of writing it, right? We have the executive branch, CMS, HHS, the White House, the federal government has the authority to write it. But we must take constituent feedback into the process because we serve the people, right? We're at the disposal of the people. Who has authority over rulemaking? So I put that sort of in orange at the top, right? And then in gray right below it, I have, well, you know, there's a lot of people, there's no reason I made anything orange, gray, or blue, but I'll just say in gray below it, I said, well, Congress, they obviously can say a lot about rulemaking. In fact, congressional members and Congress, which includes senators and representatives, they regularly say that, you know, why is this not in your rule this coming year? We want this to be in the rule this coming year. Or why is your proposed rule say this? And they're saying it for the sake of their constituents. So Congress, you know, they represent the constituents. So they're regularly doing their job, right? We have an Office of Legislation that's sort of interfacing with them all the time. So they're there working. Lobbyists and organizations, they give plenty of feedback. There's some organizations that are more adept, or not adept, they're more used to interfacing with the government than others, right? Like in healthcare, organizations that are very established at interfacing with the government includes the American Medical Association, American Hospital Association, right? I'm not going to say anything about the relationships, but it's established that they know how to communicate with the government, right? So it's lobbyist organizations. Oversight and advisory boards, advisory groups, right? So oversight and advisory groups. What are oversights and advisory groups? So there's advisory groups for sort of everything, really, but I'll say for like Medicare, there's Medicare Payment Advisory Commission, which is sort of quasi-public, right? It's, well, the employees of it and the staff are public employees, but the people who operate it sort of are this independent commission of folks that are just worried about the trust fund, the Medicare Trust Fund, which we all hope continues to, you know, needs to be healthy and not run out. by the time where, well, ever, right? The idea is that this Medicare program is supposed to last indefinitely. So there's a Medicare Payment Advisory Group, the Commission, that's an oversight or advisory group. There's other sort of oversight groups out there. There's the Office of Inspector General, which is sort of making sure that CMS is, or that the Health and Human Services is not having sort of anyone sort of infringe upon it in any illegal way, right? So there's many oversight or advisory groups. Now, why do I have judiciary in the bottom? Well, again, the judiciary branch interprets the law, right? I'm talking about the court system, right? Circuit, district courts, circuit courts, state courts, appellate courts, but then the federal court system, the appellate court system, and the Supreme Court in the end, they have authority over interpreting the law, and they have authority over interpreting, is the executive branch operating within its confines of the law? Are we doing what is legally appropriate, right? So I have them in blue here, sort of widely. And again, I can't technically say that, my orange, gray, or blue represents anything here, but it's there for you. I'll say that the judiciary branch can stop any executive branch if they feel that our rulemaking process is doing something illegal. Okay. So who has authority? So then who's aware of the rulemaking process? So this was just where I just have questions. And I'll put this out to the chat. Who do you think is aware of the rulemaking process, right? I said the government, people, meaning individuals. I mean, I'll say for me and CMS, Medicare and Medicaid beneficiaries, like now in the future, which basically could be everybody, they're the most important people. Congress, are they aware of the rulemaking process, or lobbyists, oversight groups? I have a big question mark for the orange at the bottom. So who do you think is aware? I'll put this out to the group of us. Who do you think is aware? Let me see if the chat says here. Okay, so lobbyists, right? So lobbyists keep track of legislation. They keep track of legislation. And I guess one trick here is, this isn't legislation though, right? Legislation sort of enacted Medicare, legislation created some ground rules for Medicare, but for our annual updates, this isn't legislation. But lobbyists do keep track of this. Lobbyists keep track of legislation in Capitol Hill, in the legislative branch. Lobbyists are also keeping track of how the executive branch is is sort of executing the law. So lobbyists, yes, but many of them are hired not just to influence the law and legislation. They're influenced to hire. They're influenced and they're hired. Lobbyists are people who are hired. They're hired to make sure somebody's viewpoint is made clear to the executive branch as well. So those are the most sophisticated. I would say it takes some sophistication to know you don't need to just go to your congressperson or senator. You can also go to the executive branch. Who in general, do you think that the public is aware of the rulemaking process? Do you think Medicare beneficiaries are? They're the people that are influenced the most. And I think I have here, the public probably has no clue. So thank you for saying that. So I can't comment on that, right, in a way, but I will say I'm seeing that quote, the public probably has no clue. I'll just say this, that what I think is fair enough for me to share is that, it is an ongoing concern for the executive branch. Does the people who are influenced by the rules, such as Medicare beneficiaries, Medicaid beneficiaries, and frontline providers, like people at the front lines, especially with safety net organizations, are they aware of the rulemaking process? And we worry about that. It's hard to stay on top of all this, right? It's hard, you stay on top of all your regular professional needs or your personal needs, and to stay on top of rulemaking, it's hard. So I'll just say that. Okay. Thank you for those comments there. Okay. So what matters when finalizing a rule? Now we're going to get into a specific, and let me just check the time here to see how I'm doing real quick. Okay, 1:30, good. Okay. So what matters when we finalize a rule? Remember this. So I'm going back here for a second. There's a public comment period, right? And that lasts for 30 to 60 days where anyone can comment. Then after that comment period, the agency, we're in rule writing time, where we have about 30 days, maybe more if some unusual thing is going on, before we release a final rule. Now, when we're finalizing our rule, like making our final draft, if you will, it's like writing a paper, I guess, writing your final draft. What's important? Okay. Well, what matters? Statute, right? So when I have these quotes up here, I don't know if people know what I mean when I say statute. Statute is law, right? Again, Congress passes laws, so we have to remain within the statutes. We can't do anything illegal, right? As in, if we were to say we're ignoring all these new sort of medical services that were enacted this year without any grounds, that that would be illegal, right? We have to at least acknowledge that they're existing and give a reason for how we value it or we don't value it. OGC here means that we have Office of General Counsel in the government that helps us understand what's legal and what's not legal when we're finalizing a rule. We have to do what's legal, right? Then agency priority and leadership leads there. So what does that mean? So that means that this is where, when you vote for the executive office of the president, when you vote for president, they have an impact, right? Because the White House and then all their appointees across all the branches, they're here to help us, right? All of our sort of cabinets, all of our HHS education, we have a lot of competing priorities all the time. So what is the priority regularly? And this is where we need leadership to help us know what to put it, make sure that we cover first, what to make sure we cover this year right away. So leadership really leads there. And that's where, I guess the people that are political appointees have an important place there. Again, political appointees are in the White House, but then there are also political appointees at all of our branches, right? CMS has political appointees, HHS does, FDA does. So that's where leadership is important. There's one agency that sort of affects gun violence or tries to mitigate it, called within Department of Justice, called ATF, and they're lacking leadership now. They've lacked leadership for a while. There hasn't been a political appointee there for a while. That can slow things down. I won't go into all of that, but agency priority, leadership leads, right? Beneficiary impact. So that's where the people speak. Well, we need you to speak. We need also beneficiaries, consumers, patients. We need them to speak. And when finalizing, with the people speaking to us, they can speak through public comments, which will show you that can just be done through a click of a button now. It used to be something you have to write in or fax in. That's done through, you do have to be computer savvy to do it now. You can write letters, but it's best to put it into the computer. You can do it quickly. The people speak through letters, meetings with the agency, right? You can have I go to meetings where people from outside come. And what kind of people, I'll just ask this question, who do you think are people that are meeting with us? Do you think that they're, organizations? What are they? Are they sort of all lawyers? Are they all, are they all representing sort of consumer agencies? Are they individuals? What do you think is required to meet with us? Does anyone have any idea? I'll wait just a couple of seconds, see if anything comes in the chat. Is there any requirement for who requests a meeting with CMS? So you have to have a pulse, or I shouldn't put it that way. You have to be, I didn't mean to be facetious. You have to, you have to be a person who's communicating with CMS. It can't be sort of a bot, you can put it that way, right? Okay, so I have a comment here. I think anyone can, but you probably mostly get orgs like AARP for Medicare issues. So the commenter again, Isha Jane, thank you. Anyone can, that's absolutely true. Okay, so anyone can. All right. So I'll say that, we have meetings with organizations. We have meetings from representatives from the Hill, right, from Congress. We have meetings with individuals. Usually those individuals aren't beneficiaries. They aren't usually sort of patients, right, or just consumers. Not everyone who's a beneficiary is a patient all the time. They're just, most of the time we're not patients, even though we're receiving Medicare or Medicaid, right? But we can have meetings with those. I haven't had many meetings with patients, but maybe that's my problem. We have meetings with sort of think tanks, people that are sort of coming from think tanks. The AARP is brought up here. So I'll just ask, does anyone know why the AARP would theoretically be very important for Medicare? I'll sort of say the American Association of Retired Persons represents people who generally have reached the Medicare age, right? Age 65 is supposed to be the retirement age. Those kind of things are shifting nowadays in a lot of ways. But AARP was supposed to represent sort of Medicare beneficiaries. So you'd hope, and we get communications from the AARP. Absolutely. I'll say that again, the thing that's very clear is, if we're dealing with healthcare payment, organizations that get paid, right, or that represent people that get paid, they are very good at engaging with us, if I can say that, right? So we could say providers and suppliers, people that receive payments are very good at engaging with us because they need to for their livelihood. I'd say beneficiaries probably should be engaging with us for their livelihood as well. And that's all, I guess I can subjectively say this is, generally speaking, I do not hear from consumers or beneficiaries or groups like AARP as much as I hear from providers or supplier groups, people that sort of get paid, not people who are receiving healthcare services. I'm not commenting right or wrong. Logical outgrowth, what the heck does that mean? Has anyone heard that term? I'm guessing no, it's logical outgrowth. Anyone heard that term? I'll give it 5 seconds. I'll give 5 seconds for 5, 4, 3, 2, 1, 0. Okay, so logical outgrowth means that when we're finalizing a rule, making our final draft, we can't come out of left field with something, if I can put that term, left field, meaning it has to be in the proposal or it has to be in the comments, right? It has to be very clear why we're choosing to do this. If CMS decides that, and this is hypothetical, that we're going to pay for stargazing therapy, right? I'm making something up here, not to be facetious, but to sort of make sure I'm not disclosing anything. If CMS decides in the final rule that they're going to pay for stargazing therapy, that had better be in the proposal, or someone in the public comments, the letter, especially we need the public comments to have something to say stargazing fits into a benefit category for this reason, right? And that's why it's reasonable and necessary for this reason. So there has to be logical outgrowth from the proposal or from the public comments. That's why the public comments are important. So either giving a letter or just clicking through and putting in public comments important. Okay, and I even put Twitter in there. Well, I won't say anything further about Twitters, but the people can speak through Twitter. As in the government sees who's tweeting on the government Twitter accounts. You can put it that way. That it's visible, right? But public comments are where we're obliged to be looking for things, and that's where we can also get logical outgrowth out of for the final draft. Where are we going here? Okay. So who's writing the rule? Again, I said this earlier, it's human beings with finite information, time, and energy. Human beings with different experiences, government officials. We took a public oath, and I said this earlier, right? And we have varying credentials and backgrounds. Again, myself and the physicians, we're not usually writing the rule, right? We depend a lot on lawyers to that, but also just professionals that are sort of writing the rule every year, drafting. People who are professional writers. And they have various backgrounds, so medical degrees, law degrees, business school, MPA is another thing I did. I strongly recommend it. It's a master's in public administration, PharmDs, RNs, PhDs. People have PhDs in anything. Some of my colleagues that know a lot about the physician fee schedule got their PhD in history or in theater, actually. So it's there are people of various credentials. We do have to, I find that just about everyone seems to have a graduate degree. Only a few people I noticed don't have a graduate degree of some sort, a graduate or professional degree. And they're coming from different sort of backgrounds. And we have a lot of people in the public health service, right, that are coming to us that are commissioned officers in the public health service. They're working with CMS for some amount of time, whether they're physicians or pharmacists or non-clinical. Anyways, so I'll continue here. How should health impact figure into these processes? Who should be advocating? What should they say? Is this a good question for all of you? And let me again just check the time here real quick. Let's see how we're doing for time. Okay, so this is good. How should health impact figure into these processes? Who should be advocating? What should say? So I guess how should health impact be figuring into these processes? What do people say? If anyone has anything into the chat, like should public health research be involved here? Should sort of patient experiences be involved here? Who do you think should be advocating? You think the AARP, like Isha Jain said earlier, they should be sort of front and center? Any comments on this? That's okay. And I guess this is more a thing for all of you to ponder, because I think the public, for all of you and the public, for everyone you sort of go home to, everyone you work with, to ponder, because everyone does need to sort of decide how, well, should I be commenting? Should I be participating? Right. I'll just say we need participation from everyone that's has an impact on our beneficiaries, including the beneficiaries themselves. So a proposed rule out there right now. Okay. Okay, so there's a proposed rule out here called streamlining eligibility enrollment eligibility and enrollment notice of proposed rulemaking, the NPRM. That just means, again, the proposed rule before it's finalized. There's this rule out there for streamlining eligibility enrollment of Medicaid. Okay, this is out there for public comment right now. So an office of CMS that's not me. Okay. Again, that makes me feel better, because I'm not sharing anything. I don't know anything private, and I can't share anything private, but this is all in the public domain. So in the summary, you see August 31st, this came out, and now it's been 6 weeks that a proposed rule is out there to streamline eligibility enrollment. Why is that important? Well, the rationale is that a proposed rule here is aimed at simplifying the enrollment processes and maintaining continuity of coverage. The idea here is that it's not standardized across the country. Every state has a lot of authority in how they can enroll and maintain enrollment and disenroll people from the Medicaid and CHIP programs, right? And you can see how that theoretically can lead to some disparity. So, why are they doing this? Well, this is a different office within CMS that sort of put out the reasoning for this. And when CMS put out its proposed rule, they said, well, this is something that they cited, that Medicaid churning, meaning people going into and coming out of Medicaid, affects how much they seek care. It's kind of intuitive, but we needed science to confirm this, right? Just so that there's a economic reason, there's a scientific reason for why we're doing anything about it. So there is Medicaid churning out there. If folks didn't know that, at this stage in the American sort of healthcare system, there's somewhere 20 to 30 million sort of uninsured people for over the course of a year. And then if you sort of take people that are uninsured for just 6 months or X amount of time, that number grows because there's churning. There's people that get into Medicare and Medicaid and come out and get in and sometimes get back in again. Anyways, so this can affect healthcare. The rationale here, and this is all public information, right? This was in the proposed rule that that in 2018 that these offices felt that Medicaid and CHIP enrollment decreased over 1.5 million enrollees, and state enrollment policies were driving a factor. Say Tennessee, Arkansas, and Missouri were cited here. Some of you may be from these states. In Missouri, enrollment dropped by 70,000 in 1 year, including 55,000 children, mostly due to families not returning a mail renewal form created by the state's new automated eligibility system. So the mail renewal form, so now the concept is that we should be able to electronically file renewals, right? You shouldn't have to. That's one of the ways that in the proposal that we want to streamline things, that the CMS is proposing to streamline things. Arkansas and Missouri required the use of phone or mail for eligibility. Again, you can miss mailings, right? So simple. So you see what the rationale is. Over in Tennessee, over 148,000 people left the Medicaid rolls because the state started conducting manual eligibility redeterminations. So you see the rationale. So I'm seeing stuff in the chat here. Okay, thanks, Sarah. Okay, and just closing this. Okay, and I'm seeing. Is there another question? Okay, and I think this question just came here. 1 second here. 146. So I'll just go ahead and say this. How can we be more informed? So I'm going to go through this rationale real quick and then get to where these rules are. How can we be more informed? Well, okay, let's get to that. And so the rationale again: children can lose coverage, especially vulnerable children. Or if you're on CHIP or Medicaid, that means you usually have a little less resources than if you don't have CHIP or Medicaid. There's people age 65 and older who are able to sort of have Medicaid on top of their Medicare. And they could be excluded. There's no overarching national guidance before this requiring clear and consistent timeframes. All right. So the idea here, CMS has proposed, and I know these slides are busy, but I guess I didn't want to sort of put my own opinions here. I just want to post what's public, that to streamline things, right? To make it straightforward across the country that, well, there's no reason to have some of these may be considered barriers to enrollment, right? And unnecessary barriers. Some may consider that, right? I'm not giving my opinion, but that's a proposal that's out there. So the idea here is to, to streamline things as much as possible by automating enrollment, using sort of data sharing when possible, letting people sort of click on, well, just use my taxes to figure this out, eliminating the requirement to making it possible to enroll for 12 months at a time, eliminating things like having in-person interviews, using pre-populated renewal forms, providing a 90 days of reconsideration after termination, right? So limit requests for information on a change in circumstances. There used to be things, when I used to study this in grad school, there used to be things like asset tests, right? Like as in states would require that, that you even declare if you have a car that's worth X amount of dollars or something. And if some of this seems familiar to you, to some people, and not familiar to others, that's because states are all different, right? We have so many different states out there, and they're all dealing with different things. I can say this much though: during economic downturns in general, some states feel it more than others, right? They feel their own Medicaid part of the budget, their own state part of the Medicaid. There's Medicaid is federal and state. They feel their state Medicaid budgets more so than other states. Okay, so let me just keep going. I won't go into this. And they're also saying that states have to keep more regular records so that they can have this streamlined enrollment. So there's no required record keeping regulations right now across the nations. So if you wanted to make a public comment, you can make a public comment. You can click here, which sort of lands you here. I'll put this in the chat. Let me see if I can put this in the chat here. I'm going to put this in the chat, right? Copy this and put this in the chat. Everyone can see this. So you can click here and see that there's the comment period for this person. This rule has about 25 days left in it, right? And it lands you here, right? It lands you to this website where you can read the comments that are out there. You see, if you look right now, I downloaded this for like a previous talk about several weeks ago. There were 4 public comments, and there's only 20 now. There's going to be, when these public comments are out there, the idea is that the public can also argue. So even if you think your argument is intuitive and just obvious, if you look around, well, there's a reason why we're putting this out there. Some states have felt that these administrative requirements were necessary or appropriate for them for a long time. So there's going to be plenty of people that think that streamlining at least is not what they've been doing, right? Nationwide streamlining isn't what they've been doing. So if you feel a certain way about this, especially for your states, if you're one of the states that's sort of invoked, especially in this proposed rule, then you should make your thoughts known. Either way, again, I myself as a federal employee, I have to tell you that you should make your thoughts known either way. But don't assume that your way, that whichever way you're saying is just so obvious that you don't have to do anything. You should probably, it makes sense to participate. Don't assume that your way of thinking is just going to drown out everything. Now, so let me continue here. Again, who's writing the rules? Again, the reason I'm pointing this out is, well, if you choose to participate, remember that there's people like me, that's sort of involved in writing the rules. Again, I do more consulting, but people are regularly asking me and other doctors, what does this mean? What does that mean? And they're asking us to even draft things for them, right? So we might be drafting parts of the rule. We're not responsible for writing the final rule. And my boss, and then I have like sort of 2 or 3 layers of bosses in the White House who, have these rules have to go through clearance. But we're human beings. We're government officials that we're here to protect the people, and we have varying credentials and backgrounds. I think I'm the only psychiatrist in CMS, and I think I'm the only psychiatrist in CMS for the last 20 years, which makes me nervous, right? Because how do people look at behavioral health? I mean, anyways, so please give input, because there's a finite amount of people in CMS, finite amount of information, time, experiences, and credentials at CMS. So please help. And so the takeaways here, and I think we can get back to the second question, is that there are many federal functions, including HHS, your healthcare, which matters to everyone at DFA, require notice and public comment, notice and comment rulemaking. The nation's public health and healthcare system can be influenced. Notice and comment rulemaking is transparent. You may think it's hidden somewhere, but it's right there in the Federal Register. It's right there. We can go back to the website, and what's the link in the chat. And federal agencies will consider all input given during notice and comment rulemaking. So let me sort of stop there, and I'll sort of click on this because someone sort of asked with the Federal Register.gov. And let me say something about how can we be more informed? Okay, so let me also just check the time. How are we doing here for time? Okay, 7 minutes, good. Okay, how can we be more informed? So you could be monitoring the Federal Register, right? Which is hard to do, right? What else can you do? You can become really, there's lots of different ways. I would like actually people to sort of put in the chat how they suggest it, but who stays the most informed? It seems like organizations, people that are organized into organizations that keep track of this are the most informed. As in people that can hire professionals to keep track of this Federal Register are the most informed, right? And now that's not to mean that you have to be able to hire a lobbyist or something, but I guess I'll just say that, DFA stays informed on a lot of things because of our network, right, of people involved in things. I'm on, for me and DFA, I could certainly, like when they asked me to talk about rulemaking, I said, well, this rule is out there and I think this matters to DFA. Again, I keep myself sort of, I need to be somewhat agnostic to things, but I can sort of put this out there that, well, here's a rule that matters to you for affordable access to care. So your network matters, right? So if you can sort of, if you're working with people in a professional network where people share information, if you can work with groups that, like, theoretically lobbying organizations keep track of these things, but lobbying organizations sort of try to influence politics. You don't need to be a lobbying organization to stay on top of this. You can just have you can just sort of have someone that sort of keeps track of this. Obviously, congressional offices, they keep track of what's going on, right? So you can stay in touch with your Congress people. I'll just ask this. Do people what do people think? How do you think you can stay informed, or how can the and I guess one question that I guess would matter to DFA, like Angie and everyone that's here, and DFA's board of directors, which I also wear that hat. How would you like us to stay informed of these things? How often would you like to hear about this? So, I guess I'll ask the participant. I'll ask people that are tuning in right now. What would be the most convenient way to stay informed? Is emails once a month sort of a way of staying informed? So again, thanks, Isha, I think, for participating again here. A newsletter with NPRMs, weekly or monthly, would be good. Right. So if we had, so again, what do we try to do? So that's how. So we could try to regularly keep track of things. I'll say, so that could help us. So I'll just say that I think this actually feeds into the other question. Someone asked, a preventive medicine resident asked how you got involved with CMS. It's hard to stay informed of everything. I'll say that there's always a need for more doctors, especially doctors that are working for like Medicare and Medicaid beneficiaries, doctors that take insurance and work for safety net organizations. Obviously, we need them to get on usajobs.gov and come come sort of working, come and work for the government. And that's a way. And if, and you can work for the government like I do and not break any rules and still sort of share public information with your partners outside of the government. One thing I think you've been able to tell is I've been careful, like I'm not sharing anything that's private, right? Like I'm not saying that, oh, Dr. So-and-so or organization so-and-so is negotiating this and this with CMS. I'm just saying this is what's publicly out there. So we need more people to be aware. We need more doctors in public service. We need more doctors in the government, and we need more doctors and public health organizations and consumers, like whether it's doctors or consumer advocates or people that sort of hang together. Like that's something I believe, that doctors and consumers together should be monitoring this stuff and working together more. I'll just say that, So, I think if there's no, so I think we've went over a lot, and I'm glad that people participated today. Let me see if there's anything. So we're at 1:58. I think I'm going to repeat some things here. So I'll just repeat some things that are here. In the chat, DFA has a federal legislation and policy committee. They'll be working on rulemaking. You're all welcome to join if you see that. So if you see, please get in touch with our folks here. Angie Becky, who's on our list here, is our executive director, but there's lots of ways to get to DFA. Ashley has put DFA's link here on the website. So there's lots of ways to get involved, and please fill out our survey. I don't know, Ashley, is there any sort of anything less to say? Anything we want to close with? I'll stop talking because I can ramble.
Arca, we just wanted to say thank you so much for sharing today. We really appreciate you walking us through the rulemaking process, letting us know who influences the rules, who versus who actually shows up. And most importantly, thank you for elaborating on the power of the public comment.
Oh, thank you. And I guess thanks Ashley and Angie for producing this, and Marlu, who couldn't be here, the executive staff. So the DFA organization is doing its absolute best to sort of be the conduit between advocacy and public service that's keeping all the clinical folks very appropriately busy during the day. I'll just also share this, that the DFA's FDA task force is especially involved in sort of advocacy with the government. I'll put that out there. So please join us and get involved. And we want to continue to get better at this. And I personally also want to see doctors and consumers advocating together. Again, consumers meaning they're not always patients. So I'll stop and just say, I guess, thank you everyone, and have a wonderful, wonderful day. Are there any last things here, Ashley? I'll stop talking. I don't know if I'm the best person to close anything.
No. Just before we close, just a quick reminder, please fill out the survey so we can learn more about you and what sessions you'd like to see in the future. Thank you for being here and for all that you do on behalf of your patients as well. The event will be available for viewing on DFA's YouTube channel afterwards. And please remember to follow us on Twitter, LinkedIn, and Facebook to stay up to date with all DFA programming, events, and ways to get engaged. We really appreciate you showing up here for us today. Thank you again, Arca, and everybody else that put this together.